All
think the
right, good
attendance is
evening.
rolling in.
Yeah, just see everyone's popping in. Good evening, everyone. All right, let me just see. Good. Looks like I've got a great turnout tonight. Thank you all for joining me. We'll wait a few minutes for everyone for the stragglers and everyone. There we are. Let's try and find a Q&A thing. There we go. From Wyoming. Thanks for making the effort, John. Really appreciate that. Must be really early for you there. Okay, we'll wait a few more minutes for more people to join, though. We've got a Q&A box on so if people have any questions during the webinar, feel free to type them in, and I'll probably answer questions at the end because I might answer some of them during the process, and we'll just let the flow of the lecture go smoothly without me having to jump and forth back through the questions. But I've also got Joel and Nick from Good Sleep Co. hosting me tonight. So I'd like to thank them for inviting me. We'll wait another minute for a few more late stragglers, and then I reckon we'll get into it. Okay. Right, yeah. I reckon let's get started. This whole meeting's going to be recorded as well, so you're more than welcome to watch it again. And the people who come late can always rewatch the start. So I'd like to thank Good Sleep Co. for organizing this webinar and inviting me to talk to you all tonight. Basically, how this all started, I've been working with Good Sleep Co. and the team for, oh, hang on, just got a message my audio not working. Oh, it's all good? Okay, no worries. All good. All right. Yeah, just send me a message, Joel, if there's any cut in audio. I've got my phone here, I can see it. So, yeah, thank you for inviting me, Joel, and Good Sleep Co. to present this webinar. I've known Joel and the team, been working with Good Sleep Co. for many years, and they've just introduced a new sleep monitoring device, which I've been using for a lot of my patients. And this brought about tonight's topic about talking about sleep studies because it's a um, very important topic we all need to know if you want to get into this world of sleep medicine and sleep apnea. And I'm going to explain how sleep studies work, how I use them, the different levels, which ones to use, and I'll also demonstrate how I use Good Sleep Co.'s sleep test device as well. So, This is my background. I've been in the field of TMD and sleep apnea for over 10 years now, and I purely see patients for TMD, sleep apnea, and bruxism. I don't do any general dentistry. It's been like 6 or 7 years since I last did a filling, so no general dentistry, just pure TMD and sleep. And last year, I also got my certificate in medical acupuncture, which was mostly for pain, but it can also be used for helping with sleep apnea and other sleep conditions like insomnia. And every year I run a TMD and sleep mini residency. I run it in Australia, Melbourne, where I have my team of physios, chiros, osteos, sleep physicians, ENTs, you name it. I get every health practitioner I know to come lecture with me to teach dentists and any health practitioner interested how to treat TMD and sleep apnea. And I also do run my course in Malaysia as well. And this year's Melbourne, Australia cohort has sold out, but there's still spots available for Malaysia. And this is just basically a quick spiel of what I do and teach in my courses. I teach people how to palpate muscles, do bite registrations, feel, know where the different muscles of the neck and TMJs are. Um, and we get my physios and chiros and osteos come on board as well, teach how to do physio, massage, and unlock TMJs. And I also teach acupuncture and dry needling as well for like masseter pain, how to teach you how to stop your patients gagging. Very useful skills. So let's jump into the tonight's topic. Before we go into sleep studies, we're going to first talk about what sleep disorder breathing is, because a lot of you, as general dentists, may have never treated a patient with sleep apnea or even know what to ask for. So let's go into the basics of sleep disorder breathing. Sleep disorder breathing is the main term we should be using to incorporate snoring, sleep apnea, and upper airway resistance syndrome. Basically, SDB is a syndrome of upper airway dysfunction characterized by snoring, increased respiratory effort, increased airway resistance, and pharynx collapsibility. So this is what we're looking at. SDB incorporates snoring, upper airway resistance syndrome, or UARS, and OSA. Now, most of us as dentists are focusing here on OSA. Then we think we often make the mistake of separating these three entities into three separate conditions. But the reality is, SDB is the umbrella term of snoring, UARS, and OSA. And snoring, UARS, and OSA aren't separate entities. They all are part of one disease and they all lead to another. So this is what we are really dealing with. Snoring will lead to UARS, which will then lead to OSA, and OSA will be mild, moderate, or severe. And this is the big mistake lots of doctors and dentists will make. We'll be focusing purely on OSA. So this is the end stage of disease. Whereas reality is, disease has started straight away here at snoring. And we think, oh, person is snoring, they're not choking, it's fine, it's normal. But reality is it's not. It's going to lead to something worse later if we ignore it. So as dentists, for example, we'll see patients come in. If they've got a bit of plaque or calculus buildup, we're already on top of the patient saying, hey, you need to clean your teeth, otherwise you're going to get periodontitis and gum disease. We don't wait and say, oh, no, just leave that calculus, don't worry, we won't clean it. Let's wait until you've got advanced perio, then we clean it. But that's not how we're taught in dentistry. And that's basically what we're doing here with sleep apnea. We're saying, you've got sleep, you don't have sleep apnea yet, you're just snoring. Let's wait until it gets worse, and then we'll treat it. And I also do see patients where they've already been diagnosed with sleep apnea, but the doctor will say, oh, it's only mild sleep apnea. Don't worry about it. Just leave it. Once it's gone worse and you've got severe sleep apnea, then we will treat it. And it just doesn't make sense. And especially these patients will then get frustrated. Some of them will come complaining to me saying, my doctor refused to treat me. I'm feeling tired. I'm unrefreshed. My snoring is keeping my wife up all night. I want to treat it, but they said I'm not severe enough to treat. And they won't be giving any other option. So that's where we as dentists can really fill in the blanks and help these patients who aren't getting the proper treatment or the proper assessment and diagnosis that they need. Because most of these doctors will just be focusing on CPAP and they'll say, oh, you've got snoring or mild sleep apnea. CPAP is overkill. You don't want to wear a breathing mask all night, pumping air down your throat when you've got snoring. Let's wait till it gets worse and then we can treat it. The sleep apnea splints or mandibular advancement splints, which is what we can make, are very effective in snoring, mild, and moderate sleep apnea. They still can be used for severe apnea, won't be as effective in some cases, but I've treated many severe sleep apnea cases with mandibular advancement splints very successfully. So we definitely can offer a service to our patients that they may not be being offered. So when we go into the definition of these, snoring is loud upper airway breathing sounds without any choking or hyperventilation. So apnea means choking. And then we've got upper airway resistance syndrome. So UARS is where people are tired and sleepy snorers, but they don't have any apneic episodes. So they're sort of in between snoring and apnea, but they don't fall into any of those categories yet. They're in between. And then you've got OSA and OSAS. Now, this is what most people don't know about. They don't know that there's a syndrome with OSA. So OSA is where there's repetitive complete cessation or attenuation, which is a hypopnea, where it's a partial choking episode, secondary to either partial or complete obstruction of the airway. Now, when you add the syndrome into it, the syndrome is when people feel symptoms of sleep deprivation. So these people will feel fatigued, unrefreshed. They'll have low concentration, maybe brain fog. They might even have other symptoms like chronic pain, TMD, headaches, because if they're not sleeping at night, they're going to increase more inflammation and pain. So this is where we can miss a lot of our patients. They'll come into our clinic, they say they're snoring, but they feel fine. I feel completely fresh in the morning, I don't have a problem. And the doctor will say, okay, you have no problem, you're snoring, you don't feel unrefreshed, let's just leave it. But this could be an OSA patient who has severe sleep apnea. I've seen people with severe OSA where they're choking 80 times an hour, but they feel fresh as a daisy in the morning. 80 times an hour choking is a walking heart attack or stroke waiting to happen. Just because they feel fine doesn't mean they are fine, which is why if anyone's snoring or having any signs of choking or snoring, even if they feel fine, they should do some sort of screening and sleep assessment. And this is where the sleep studies can come in. So if patients don't want to do a full-blown hospital or type 2 sleep study, we can do these type 4 monitoring devices, which could open the gateway to make them want to go do a hospital level 2 sleep study. So that's why it's important anyone who snores or has some sign of airway blockage at night, even if they don't have any symptoms of fatigue or unrefreshed, we have to talk to them about the possible consequences of like heart attack or stroke or high blood pressure and see if they're interested in doing a sleep study. So this is what we look for when we're diagnosing sleep apnea. We use these different scaling grades of AHI or RDI. So the RDI is the Respiratory Disturbance Index. It's basically the number of times people stop choking or snoring or they're not breathing properly every hour. So if your RDI is like 10 times an hour, that means you're mild apnea. As I said earlier, I've seen some people where it's like 80 times an hour and they're severe sleep apnea, but they feel perfectly fine. And there'll be a lot of male patients because males, we have more testosterone. And if you have more testosterone, it makes us feel more refreshed. Whereas females, they would be the ones who normally feel tired because they have less testosterone and they have more estrogen and progesterone, which will make them more fatigued, more sensitive to changes to the body. So most female patients have sleep apnea. They come to me feeling unrefreshed. But most male patients who come with sleep apnea to me, they feel fine. They've come to see me because their wife is elbowing them every night to tell them to stop snoring. So those are the subsets of people you will most likely see. Now, that was adults. When we look at children, the classification is a lot more different. It's a lot more strict. Any snoring is not normal. As you can see in children, if their AHI or RDI is 1, it's mild sleep apnea. If it's 10, it's severe sleep apnea. Whereas in adults, if it's 10, there's still a mild sleep apnea patient. So that's why, especially in children, we have to be on top of it if we notice any snoring, because if they're snoring, they probably would have some AHI of 1 or above. So this table just shows the differences between mild, moderate, severe in adults and children. And just remember as well, if a kid has maybe mild OSA at 5 years old, it's just going to get worse and lead to UARS and mild, moderate, severe sleep apnea by the time they're like by adult or 20 years, 30 years old. So that's why we have to get in there early. So this is just another example of a sleep study, sort of highlighting some of the problems with these scoring systems that we use. So this is a child, or you could say a young adult almost, 17 years old, but we're legally adults in Australia when you're 18 years old. So 17 years old, RDI is 8.8 times an hour. So you would say as a child, they're in the moderate sleep apnea, almost severe sleep apnea as a child. Though next year, when she turns 18, she's no longer going to be severe because now she's an adult. So that 8.8 is now mild sleep apnea as an adult. So all we have to do to treat her is just wait 1 year and then she's treated. She's no longer severe apnea, she's now mild apnea. So you can see where there can be some issues with these sort of scorings. So especially when I see young adults like in the 18, 19, 20 years old and they've got mild moderate sleep apnea, it's making me think, yeah, you might have an AHI of 10 and you're 20 years old, but maybe you had the AHI of 10 when you were a 15 years old. And that would have made you a very severe child sleep apnea patient. So those are just things to keep in mind as well when you see your patients. All right, so let's now go into sleep studies. You've now got a basic understanding of sleep, AHI, RDI. Let's break it down into how we use it for sleep study. So we've got 4 different types of sleep studies that we use to diagnose our patients. Type 1 is a full in-lab sleep study. So PSG is polysomnogram. That's the proper medical term for sleep study, PSG. And then you've got the portable ones. These are ones you can take home. There's level type 2, type 3, and type 4. And I normally use, most of my patients are using type 2 sleep studies, though I'm mostly using the type 4s a lot these days with Good Sleep Co. For my monitoring and follow-up appointments. So this is a level 1 hospital PSG. It's normally in a hospital or a lab. You're supervised. People will be watching you. You can use this to diagnose everything, not just sleep disorder breathing and OSA, but you can look into like insomnia, REM behavior disorders. Well, not so much insomnia. I do other tests of insomnia, but I can look into sleep epilepsy, REM behavior disorders, and every sleep condition you wanted to. Night terrors, sleepwalking, and how they differentiate between a level 1, level 2, 3, and 4 is they use different channels. So the channels are all the different readings we would get, such as like EEG, brain activity, nasal pressure, oximetry, heart rate, etc. So because it's a level 1, normally we'll have lots of channels, and they also have sometimes they can video it, they can audio record it, and because there's someone there, if something falls off, they can put the plugs and machine back on if it falls off. Now, level 2 is when we get into the portable home sleep studies. Now, these are unsupervised, but the failure rate isn't too high. And 95% of my patients do level 2 sleep studies, and we rarely have to redo them. Now, they can diagnose majority of sleep disorders, not just sleep disorder breathing, but most of them I'm using for sleep disorder breathing. They can detect apneas, hypopneas, and arousals. Now, arousals is a sleep term we use to measure how many times people are waking up during the night. And with the difference between level 2 and besides being at home and rather than going to a hospital, it has less channels than a type 1. So it normally has minimum of 7 channels to be classified as a level 2. Now, level 3 is still a home-based sleep study, but it has less channels. And it's got 4 channels, minimum of 4 channels, whereas level 2 had minimum of 7 channels. Now, for level 3, it can only diagnose snoring and sleep apnea. It won't look into any other sleep disorders. It doesn't give any info on the quality of the sleep, so there's no like brain, no EEG. Won't give much or any information about arousals or sleep stages. It won't detect hypopnea sometimes. The AHI can sometimes be less compared to type 2s. So because it's giving less information, it may underestimate the AHI. Though it is useful for follow-up reviews and especially if you're using a mass and the patient doesn't want to do another type 2 with lots of electrodes or they don't want to go to hospital, this is where level 3 and level 4 sleep studies come in. So this is the last sleep study, level 4, the most portable, easiest sleep study a person can do. Unfortunately, we can't use it for diagnostic criteria. It can only be used to identify OSA and snoring, but because it doesn't have as much channels, medico-legally in Australia, we can't use it as a diagnostic study. Though in other parts of the world, such as Southeast Asia, it is very useful for those situations where it's limited access to getting to level 3, 2, or 1 sleep studies. Now, it doesn't give much information on sleep quality or EEG. There's no arousals or sleep stages often detected, though it is very useful for monitoring and follow-up, which is what I'm using them for a lot. So this is just a summary of some of the sleep disorders we could look out for in the sleep world. So as dentists, the main thing we would be treating would be OSA and snoring and UARS. Though we could also see patients with restless leg syndrome, hypersomnolence, narcolepsy, parasomnia, sleep deprivation. And why these are significant to us as dentists is a lot of these sleep disorders can cause bruxism, which can then cause TMD. So for the snoring, breathing part, not so much importance. But when you go into the pain, TMD, and Bruxism world, very important. Because lots of people with restless leg syndrome or movement disorder will have bruxism. Lots of people with insomnia will have bruxism. Lots of people with REM behavior disorders and sleep deprivation will have bruxism. And all that will cause more overloading of the masseters and TMJ, cause TMD. But that's not a discussion for tonight. TMD is a whole different topic. Tonight, we're mostly focusing on the OSA and the snoring. So this is basically what you could see on a full-blown PSG sleep study. Now, don't let this panic you. Don't worry about it. I'm going to break it down easily. You don't need to know all this information unless you're going to like do a fellowship or further education exams. For the patients, you just need to know a little bit of information so you can read the study to them. So with our normal sleep cycle, we on average we spend about 6 to 8 hours a night at sleeping. That's ideal. And we in that 6 to 8 hours, we get around 4 to 5 cycles of sleep during at night. We go through two different states of sleep. We go through NREM, non-rapid eye movement, which makes up majority of our sleep, and then REM, which is rapid eye movement. And each cycle goes for about 90 minutes. So overall, as a human being, we go through wakefulness, then NREM and REM sleep. And the brain, neurology, muscle activity is different in every single state. So these are different stages of sleep that we got. So NREM is broken down to 1, 2, and 3. Used to be 3 and 4, but now it's only 3. And then you got REM. Now, REM is the paradoxical sleep. REM is where you'll be dreaming at night. So this is how we determine what stage of sleep we are in. We use the EEG activity to measure brainwave activity. So when we look at EEG, there's the amplitude and the frequency. So when we go through the different stages, the EEG activity changes. So the more deeper into sleep we go, the more wider the frequency and the more deeper the waves. So you can see here N1, when it's light sleep, it's very short waves and very short. They're not that high. When we get into N2, you can see it's getting a bit wider and longer or higher. And we can see N3, and this is back when they had N4, very big waves. And they call these delta waves. So often they call another name they call deep N3 sleep is delta wave sleep because you've got those deep delta waves manifest on the EEG. So this is what it's like when we're awake. So you can have awake with your eyes open. The brain activity will be like this. When your eyes close, you can see it gets even faster when the eyes are closed. When the eyes are open, it's a bit more wider. They call it beta waves. Whereas when your eyes are closed, it goes to alpha waves. Then when you go to stage N1 sleep, light sleep, you can see it's getting a bit, what's the word? A bit more wider again, the frequency. You can see it looks similar to awakefulness with eyes open. Then as we go to stage two sleep, you can see it's getting more deeper, and you can see we get these different, you'll see these different complexes called sleep spindles or K complexes, which are exclusive to stage two sleep. Deep sleep, so N3 delta sleep, you can see you got these big delta waves. And then REM sleep, rapid eye movement, very similar to being awake, which is why they say REM sleep is the awake sort of stage of sleep. The reason why REM sleep has lots of activity is REM sleep is where your brain is working. If you want to learn something, if you want to memorize before an exam or a test, REM sleep is where it consolidates your memory, helps do all the learning processes, helps you remember things. So people have very poor memory, or they find it difficult to learn, or they're doing very poorly at school. They may not be having enough REM sleep and then their brain won't be learning and processing new information that they learned during the day. Now, we also use EMG, electromyogram, to measure the muscle activity. So normally they place sensors on the chin and the legs to measure leg movement from restless leg syndrome. They also use it to stage sleep, especially rapid eye movement REM sleep. Though if you want, you can also use the EMGs to measure for bruxism. Though if you want to measure bruxism, you have to ask the lab to put it on the masseters because they may not be put on the masseters. They might just be put on the chin. So you can see how the EMG activity changes in the different stages again. And then obviously we're looking at eye movement, hence we'll know whether it's rapid or non-rapid eye movement. So in the NREM stages, it's non-rapid and it normally the eye movement gets slower and slower. And then in REM sleep, it gets faster. And then we always want to look into the breathing events. So they'll look at like airflow and apnea. There'll be cessation of airflow, and in normally to be classified as apnea, the airflow has to stop for at least for greater than 10 seconds. Hypopnea is a reduction of 50 of greater than 50% in airflow for greater than 10 seconds, and is normally associated with oxygen level desaturation. So you can see here, there's still some airflow, but it's reduced by at least 50%. And then RERAS is a respiratory effort related arousal. Now, this is how we measure UARS. So RERA is reduction in airflow, which results in an arousal. So you're like not breathing properly and you wake up, but it doesn't meet the desaturation criteria for hypopnea. So for hypopnea, your oxygen has to drop by 2, 3, or 4%. For RERAS, there won't be. So that's how we measure O2 saturation. We'll use a pulse oximeter with our sleep study. And ideally, we want the O2 sats around above 90%. Using more strict criteria will be 96 to 98%. Anything below 90 is then mild, moderate, or severe desaturation. Oh, and they'll also measure something called the NADA is the minimum O2 oxygen level that the oxygen desat that the machine dropped to during the night. So what classifies as a good night's sleep? Well, to have a good night's sleep, we need to have the correct amount of sleep, the correct proportions of N1, 2, 3, and REM, the correct order, and have ideally unbroken, uninterrupted sleep. So these are the different stages again, 1, 2, 3, and REM sleep. And these are the ideal percentages we want to stay in each stage. So most of our sleep will be in stage 2. Then there'll be the next biggest proportion will be in REM or N3 sleep. And N1 sleep takes up the least amount of time. So we don't want to be N1 sleep much. N1 sleep is normally just at the start of the night when we're just falling to sleep. And this table just sort of shows a summary of the different EEG, EOG, and EMG characteristics you could see. But to be honest, I never show this sort of stuff to my patients. It's not, we don't need to know this. This is what the sleep scientists would go through on the sleep side to do the diagnosis for us. So then we can just read the report without having to worry about all this stuff. This is useful, interesting stuff to know if you ever want to go into like fellowships and get extra credentials. And when we do a sleep study, we also normally get a hypnogram. Now, you rarely see something as normal as this because the patients I'm normally doing sleep studies for are normally unhealthy. But we will normally go through awake, then down to N1, then 2, then 3. Then from 3, we'll go to 2, then to REM, and then back to 2, then 3, 2, then REM, etc., etc. Now, these are all the cycles. Remember, I said we get about 4 or 5 cycles a night, which lasts for 90 minutes. So at the start of the night, we normally get a lot of N3 sleep and not much REM. Then as the night goes on, you can see we're getting less and less deep sleep and more REM sleep. So this is why it's very important to have uninterrupted sleep. So if you are snoring at night, that will wake you up and interrupt your sleep. If you're clenching and grinding at night, having TMD at night, that will interrupt your sleep and disturb the sleep pattern. So let's say I'm going to sleep, I'm here, go to N1, N2, N3, then I start snoring and choking. That interrupts the cycle and it will make me start this whole cycle again. So then I miss out on the REM sleep. And I won't go to cycle 2, 3, or 4. I'll just pretty much start here again. But now, instead of it being 11 p.m., it's now 1 a.m. and I'm restarting my cycle. So what's just happened? I've now interrupted the cycle and I've just disrupted the amount of deep sleep and REM sleep I'm getting. Because I keep interrupting my sleep every few minutes or every few hours. By the time it's like 3 or 4 a.m., I'm trying to get to sleep. I've now missed all the deep sleep I should have got. And now the brain has, oh, I need to catch up. How am I going to get my REM sleep? So now I'm going to miss my REM sleep as well. So that's why it's important to have proper uninterrupted sleep. Sleep at an ideal time. Don't sleep too late because then you'll also eat into these cycles. And we don't want to have any other things which could impact things. So such as like caffeine too late at night, eating too late at night, have a nice cool bedroom, etc. So that's where sleep hygiene also comes into play because that could also interrupt our sleep and disrupt these cycles. So this is just some examples of different hypnograms you could see. So this is like something relatively normal. This is where you can see there's no delta sleep, so there's no N3 or 4. And you can see here there's barely any good sleep at all. All mostly in there's only one sleep and got some REM still somehow, but there's no sleep at all going on here. This is just from one of my other patients' sleep studies, just showing another hypnogram, which looked pretty normal. You can see there's still some arousals where they're tossing and turning a bit. Oxygen levels were dropping, some hypopneas, but it gives you a bit of a summary of what we could see for a relatively still normal sleep study, even though there were some hypopneas and arousals and O2 desats. So these are some other things that a sleep study could, other data and statistics your sleep study could give you as well, especially if it's a level 2 or level 1. I can show the sleep latency that tells you how long it took to fall asleep, the REM latency, how long it took to get to REM sleep, percentage of each sleep stage. So you don't need to memorize or remember all these sleep stages. Normally they will have it on the sleep stage for you, so it's all easy. And they'll have arousal. So those are different awakenings. So you can have the RERAs, the respiratory arousals. You could have RMMA. So these are masseter muscle activity arousals, very important for bruxism. And you can have spontaneous arousals where it just happens out of the blue for no reason. So you have these different respiratory statistics showing like hypopneas, obstructive apneas, central apneas. Haven't talked much about that tonight, but central apnea is where it's not from a blockage, it's from the brain not sending proper signals to the breathing muscles to breathe properly. So that's completely different. We don't treat it as dentists. The sleep physician needs to treat that. And then if your sleep study has the mechanisms to test for bruxism, they can measure bruxism as well. And they'll measure something called RMMA, which is rhythmic masticatory muscle activity, which is basically how much your masseters are moving and activating during the night. And often they'll have a conclusion at the end of the study. So the sleep scientist and sleep physician will have looked through it all and give you a conclusion. But be careful. Sometimes, depending on what lab or machine you're using, this conclusion could be automatically generated. So they might say, oh, from these results, this is a mild sleep apnea patient. The computer just splurts out this random generated sentences. So just be careful about that because sometimes it will say things which may not make sense depending on what you diagnose. Overall, what should you show your patients? Because they don't want to look at everything and you won't have the time to go for everything. So this is what I show my patients. I talk to them about AHI and RDI because numbers is the easiest thing for them to understand. I talk about how much they wake up at night, the arousal index, oxygen levels, how much is dropping, and bruxism. So keep it very simple to them. So this slide just shows a bit of a difference between AHI and RDI. So AHI is the apnea hypopnea index. It's just looking at the number of apneas and hypopneas every hour. RERAs is the respiratory effort related arousals. Now RDI is when it's adding AHI with the RERAs. So you can see if I do 2.1 plus 5.9, that will equal 7.9. Okay, so that's how we get the RDI. Now, if we look at this, if we just used the AHI here, that will say the patient is healthy. The AHI is below 5. They probably don't have sleep apnea. But if we add them together and look at the RDI, you'll see it's 7.9. And that will put them in the mild sleep apnea category. So it makes you have to think then, oh, does this patient, if we use AHI, it might underdiagnose. But if we look at RERAs and the RDI, could give a more thorough diagnosis. So in this sleep study, they diagnosed this patient with mild sleep apnea. And the reason why I show you this slide is most of us will get focused on numbers, and the patients will especially get focused on numbers. But at the end of the day, we're dealing with a human being. So bring it back to the patient. This patient could be 7.9 RDI, but let's just see how they feel. Do they feel unrefreshed? Do they feel tired? Are they overweight? Are they struggling to concentrate during the day? Are they having TMD or pain? And combine that with these numbers to get your diagnosis. So remember, this conclusion here might just be computer generated. Yes, it helps give you a diagnosis, but you are still the doctor. You can give the diagnosis from your interpretation because you are also seeing the patient. So keep that in mind. Just don't blindly follow numbers everywhere. So it's just an example of level 2 sleep study, just show the amount of detail you could see when you get a level 2. Level 1 would be pretty similar as well. All the different sleep stats and the conclusion at the end. This is an example of a level 3 report. You can see much less information, but still quite a bit of information going on there. And yeah, just more stats from the level 3. And then this is a very basic level 4 sleep study called the Night Owl. Very, very little information, as you can see. And then we've got the level 4 test I've been using with Good Sleep Test and Good Sleep Co. And for a level 4 test, it's actually I find it's a very comprehensive test. You can see quite a lot of information we're getting from this machine and still gives us AHI. It doesn't give us the RDI, unfortunately, but that's going to be reality with level 3 and 4. You won't be able to get the RDI, but we're using this for monitoring and follow-up. We're not using it for diagnosis. You could use this at the very start if a patient was too scared or didn't want to put all these wires on them. So if this was someone who came to me for first day, they've never done sleep study, they didn't want to, but I said, hey, just use this level 4 test. We can see what it's like. We see, hey, your AHI is 4.5. Yes, you could be healthy, but you're borderline, almost mild, moderate, severe. And also remember, this could be underestimating how severe you could be. So we can use this to help convince patients that they probably do have a problem, even though they're not feeling unrefreshed. And maybe this could be the gateway to get them to start doing level 1 or 2 sleep study. And this is just more information with the level 4 good sleep test. You can see we've got the sleep staging, the hypnogram. Gets quite a lot of information. To be honest, I was very impressed with how much information I was getting just from this simple test, and it's a level 4. So always remember, these tests are a diagnostic tool. Bring it back to what's going on with your patient. So majority of us, I think, tonight are from Australia, but I do know we have quite a few overseas people and people from Southeast Asia as well joining us. Though in Australia, to refer for a sleep study, it does cost quite a bit of money for a type 2 home sleep study. It could cost about $200 to $800 out of pocket. Medicare can rebate it and give a discount or bulk bill it, so a patient may not have to pay anything or pay a small amount out of pocket. But to get that rebate, the dentist would normally need to see a doctor, a medical doctor, not a dental, because dentists aren't doctors in Australia, apparently. So if we're dentists, we'll have to if the patient wants a rebate or full coverage with Medicare, we have to refer them to a doctor, and then the doctor has to refer them to a sleep doctor because the medical GP doctor does not do sleep studies. They can't do the referral for that. They refer to the sleep doctor who refers for the sleep study. So you can see all these, hoops and processes we'll have to go through to finally get the sleep study. That could take many weeks and months, and the patient may lose interest or may not want to do it by the end of that. So that's one problem we have in the Australian setting. And I also know in some parts, other parts of the world, like Singapore, I think, and other parts of Asia, it can be difficult to get as well. But this is what I normally do if I need the GP to do a sleep study. I write a letter template and say, hey, doctor, can you please write a referral for Bob to go see this sleep doctor I work with to order a sleep study? So at least I know by seeing a sleep doctor I know and work with, he will get the sleep study as soon as possible. And these are the criteria we also use in Australia to determine whether someone is suitable to get a sleep study and get Medicare rebate. So you have to be over 18. So that sucks if you're a kid or you're 17 years old because you won't qualify for a sleep study or Medicare discount. You have to get a sleepiness scale of 8 or above. You have to get a stop bang scale of 4 plus. So stop bang questionnaire is this, where they just have these. You have to tick things like: do you snore? Do you stop breathing? Do you feel tired? Are you overweight? Have high blood pressure? Are you over 50 years old, or are you male? So the problem with that is, I have lots of young women at 20 years old have snoring and sleep apnea, and if they're using this questionnaire, they won't qualify. So that's why we have to use other questionnaires like the OSA 50 to fill these criteria for a sleep study. So what about children? It's very difficult to get sleep studies for children in Australia because Medicare won't cover some of it or most of it. And with children's sleep apnea or children's sleep, it's normally a lot different from adult sleep. So we need a pediatric sleep physician to go through the report. And it's already hard enough to find an adult sleep physician. There's even less pediatric sleep physicians in Australia. And then if you're in other parts of the world, then it might be even more difficult to find a pediatric sleep physician. So for me, I often refer for lots of my pediatric patients to ENTs because they can do the screening, they can look down the throat and nose and tonsils and adenoid and everything, and they can also help speed up the sleep referral for a child. So this is basically what I've been using over the last few months with Good Sleep Co. It's their level 4 Good Sleep test. And basically how it works is it's a little watch device, which has a pulse oximeter. And these are some of the benefits I found while using this test. You don't need a GP or doctor to refer for it. And in Australia, you won't need Medicare referral or rebates. It's very easy access, so you can order it immediately. So you don't need to wait many weeks or months. You don't need to pray that the GP will do the referral or anything. And as I said, it's not diagnostic in the criteria, but in some areas or countries where you can't get a level 3, 2, or 1 sleep study, it's better than nothing. And I know many dentists in Malaysia that I've trained and also from Indonesia and Philippines, they don't have sleep doctors or sleep physicians doesn't exist, or it's very difficult to find. They don't have the foundations to even refer for sleep study or have sleep studies available in their country. So there's no access in these countries or rural areas. This is where we can use these machines, and something is better than nothing. Now, these could be applied for children. Yes, it might not be as accurate, but it's still better than nothing and gives a bit of an idea of what's going on. And I use them a lot as well to monitor my mass effectiveness. So if I've made a mandibular advancement splint for one of my patients, and we want to know how well it's going, rather than just going from their feedback and saying, hey, are you feeling good? Are you feeling not so good? I'll get them to take this test home, use it for a few weeks, and measure it for that period of time. And we can use it over multiple nights. So it's not just one night. I can do it for as many nights as I want over a 90-day period with this test. And it's also very affordable. So it's about $50 for the basic report, or to order it with the basic report, or $100 if you want a full-blown sleep physician report. But so far, I've just been using the basic report, and it's been very useful for me. So how you normally would use the order test as well is you use the portal resident. You just set up your account and everything, and this is where you can put in your patient's details, order tests. You can also order splints from Good Sleep Co. as well through this resident portal. So it's just my portal, just showing you some of my, examples. Is like this patient's done 4 out of his 5 tests. So far, pending health is healthy. You can see his average AHI and O2 stats during the night. So that's basically what it would show. And that's basically what it looks like. This is what you get in the kit. So this is me with the test. I've done it on myself as well to try it out. It comes with the little watch, the pulse oximeter, and the charging cable, and very straightforward to use. When you set it all up online, the uh, the resident will then send an email to your patient with a link to download this app. And the app and the email has all the instructions. It's all written out and also has a video on how to wear it. It's it's idiot proof. It's very easy to do. I just basically show my patient, here's the app, just follow the instructions, use Bluetooth, sleep with it with your phone next to you in the bedroom for the night. And worst case, if it doesn't work, you can just do it again the next night. So it's very easy to do. And because it's so small, not cumbersome, they won't freak out or feel annoyed to do it again another night. So let's finish off the night by just going through a few cases. So this is me. This is my level 2 sleep study I did back in 2013, about 12 years ago now. So my RDI was 17.4 an hour. So that puts me in the moderate sleep apnea category. And with me, I don't feel unrefreshed. I didn't know I was snoring. Then no one's ever told me I snore, but I was having lots of hypopneas and reras and during the night. So that's basically what was going on with my sleep study. You can see lots of arousals, and I had all these hypopneas, a few obstructive apneas, quite a bit of snoring, though people rarely tell me they hear me snore. So that's basically my diagnostic sleep study back in 2013. And I tried the mass on myself. Mass, very mixed results for me because my issue is not so much from my mouth or my tongue or my throat, more so from my nose. So then finally, years later, in 2024, I had no surgery. I had my turbinates reduced, and then I did a new level 2 sleep study, which showed my sleep apnea has finally improved, and now my AHI was at 3.7. So now I have no more sleep apnea, and I'm feeling much more better ever since I had the nose surgery as well. No hay fever, sleeping a lot better, breathing a lot better as well. And because it's been a year since I did my surgery and did that level 2 test, I want to know how I'm still going, whether my AHIs did change or not. And even though the level 2 test and level 3 tests, they're not so hard for me to get and easy, etc., I can't be bothered getting it. And I can't be bothered putting all the stuff on and sleeping with it every night. And if it doesn't work, I have to do it again. So I used the good sleep test on me, and I've done it over 4 nights here. And you can see, give me an average, give me an AHI for every night, my O2 stats for every night, and even if one night wasn't accurate, we can see if I'm averaging it out over multiple nights, it's giving me pretty consistent results, and it's pretty much matching with my level 2 from last year. So I'm pretty much confident that my apnea is still being controlled. So it's a really useful way I could monitor myself, and really useful way my patients can also monitor themselves. So this is one of my patients I have treated. So PK, he's got moderate OSA, RDI 17.8 per hour with mild to moderate OSA. This is his mouth, so you can see he got a bit of an overbite and overjet. So I made him one of Good Sleep Co.'s hushed Avera devices to push his mandible forward, open his airway. From day one of using it, Pico was feeling a lot better, more fresh, not snoring, more energy during the day. And this is the device I made for him, the Hush Devera from Good Sleep Co. Very awesome device, 3D printed nylon. How it works is Good Sleep Co. will give you multiple top and bottom splints. They give you, how many? They give you, is it 3? Yeah, 3 bottom splints and 2 top splints. So basically you have 5 different combinations. So you can see here, you would use 1 and 1. And then if you want to push it another 4, you go 1 and 2 on the bottom, then 1 and then 3 on the bottom. And then if you want to go more forward, you change the top 1 to a 2 and start again. If you go 2, 1, two, 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 three. If you want four, five, sixes, you could get bigger ones as well. But that's basically how it works. And it's a very useful device, very small and compact because it's 3D printed rather than big, bulky acrylic, and so comfortable inside the mouth. Really useful device. So this was PK doing a good sleep test with his mass in the mouth. So we could see over these 2 nights, his AHI is at 3.2 and 3.9 compared to his original sleep study, which was 17.8 per hour. And again, we're not just using numbers, we're going through his feedback. He's telling me, yeah, I'm feeling more refreshed, I'm sleeping better, more energy during the day. Combined with these results, looks like we've treated PK quite well. If we really want to do a type 2 to get more confirmation, we can, but I don't see a need to at this stage. So basically, to summarize everything, remember, we are treating medical condition with dental devices. So since sleep apnea is a medical problem, we need some sort of diagnosis. Whether it be a 1, 2, or 3, or 4 sleep study, some sleep study is better than nothing. And we can treat them very effectively with sleep apnea, mandibular advancement splints. So thank you all for tonight. If I will be sticking around for Q&A, and if you'd like to learn more from me, I will be holding my mini residency in Malaysia in 28th to 31st of August. So you can scan the QR code if you'd like to join up. So the early bird discount ends on the 30th of April. So if you'd like to learn like these superstar dentists I taught last year, you're more than welcome to join me there. All right. Now, before we go into Q&A, I'll probably just hand it over to Joel because he's got a good deal for everyone tonight. So I'll just hand it back to Joel from Good Sleep Co. and let him talk about what he's got on offer for these good sleep tests.
Thanks, mate. Yeah, I won't take too much time, and yeah, I'm sure you can run through the Q&A. You won't need my help there, Damien. I think you got that one. Yeah, so just with the offer, we're making available the Good Sleep Test for the next couple of weeks on our online store. Usually the retail is about $199 for the hardware, the test, and the reports. We're just keeping that at $99 for everybody that attended tonight slash has signed up, or any of your colleagues that would like to buy their own Good Sleep Test. We also will do happy to do a run through of how the platform works. We have a full onboarding team that can take you through start to finish how all the software works, how the devices work, what that can be used for, how it's used for testing, titration, and monitoring, which are usually the three main ways in which that device is used. So I'm just going to drop the code and the URL link in the chat, but you'll also get an email tomorrow with all the information. And we'll also follow up with an email with Dr. Teo's courses in Malaysia and the ones in Australia as well, and signing up and registering for those. I'll flick it back to you, mate.
No worries. Thank you, Joel. So yeah, make sure everyone that you check the chat and your emails over the next few days so you can get that deal from Joel. And I would really recommend working with Good Sleep Co. whether it be for their tests or their splints, because I've been working with them for years. And even though I've just been using this test for the last few months, I've known Joel for many years and using a splints for many years as well. So they're a really good company to work with, excellent support. And anytime I need anything, I just send Joel or the team a message and they get back to me pretty quickly. So really good customer support, and they do service many areas around the world, not just Australia. So do get in touch with them. Okay, so oh yeah, there's the code as well. So check the chat. Joel's just uploaded all there. Okay, so let me just read these questions. Got this one from Fork. I was speaking to Harry Board at ADX about the PSG4 sleep studies. He uses those only and says that it is sufficient for us to treat OSA with his sleep devices as a mass. I don't know about that because medico-legally, if you look into the most latest guidelines for mass from the American Dental Sleep Association, AADSM, the latest guidelines from 2017 From memory, they do say you ideally need a type 1 to maybe type 3 sleep study to properly diagnose OSA. Type 4 can't diagnose, even though like all those stats I just showed you does show AHI and everything. Though I don't think like you saw those EEGs, EOG, everything that a type 2 would have. It's going to give a lot more information and more precise. And I think maybe you may misheard Harry Ball, or maybe he was talking about a different sort of test, but I don't think you medico legally could use, in Australia at least, could use a level 4. Whereas like I know lots of my students from Malaysia and Indonesia and Southeast Asia where they can't get access to a level 2 sleep study because it doesn't exist there. Level 4 is great because hey, it's better than nothing. But for us in Australia, medical legality with insurance and APRA and all that, I don't know about how well level 4 would work. Um, so Hugh Fleming, can you can you comment on the case where a patient's AHI and RDI is actually worsened with a mass appliance? I had a patient recently, which a pre-treatment home sleep study gave AHI of 17.7, RDI 434. So he was treated with a mass, and the HST recorded, well, AHI went to 41, RDI went to 55. The HT was repeated with similar result. So I'd first be curious whether the patient was also feeling improvements themselves, whether they felt like, oh, snoring has improved, I feel more refreshed, less fatigue, etc., etc. Often, so sometimes the main reason I find masses can worsen OSA, whether it be on the numbers or whether it be through subjective feelings, symptoms from the patient, is often due to the vertical dimension. So if there's too much vertical, built into the appliance, the more the mouth opens, the more the mandible can drop backwards. And the more the mandible drops back, the more it can block the airway. So it might be the vertical of the appliance. Another thing as well is how much you push it forward. So there's this like Goldilocks zone when you protrude and titrate a mass. So if you titrate it too little, it won't do much. If you titrate it too much, it will make things worse. But if you titrate it just the right amount, it will fix everything. So we often think that the more we push the jaw forward, the more it will open the airway. Though, if you push the jaw too far forward, you'll also get that auto rotation of the mandible, and the mandible will drop backwards. So it's just like having too much vertical. If you go too far forward, the mandible starts dropping backwards and can also block the airway. So it might be there's too much protrusion, or maybe there's too much vertical, or it might be both. So my question for you, Hugh, would be, yes, those numbers are higher, but how is the patient feeling as well? And if their symptoms are feeling better and they're feeling more refreshed and sleep, not snoring, then I'm not too sure why the results will have increased that much. Probably something I'd talk to the sleep doctor or sleep lab about, I guess. But yeah, the main reason a mass would make things worse in my experience is normally the vertical is too high or they're protruded too much. To give you more information, I would have to see I have to see records of the patient, see what their bite is, see that how wide or small the maxilla is, how big the tongue is, how clear the nose and sinuses are, etc. So that will give me even more information. Like, yeah, hope that helps. Okay, so got a question from Ben. Does arousal mean you have to have woken up, or can it include being moved from deep sleep to light sleep? Yeah. So arousal doesn't mean you have to wake up. Arousal is basically what you've just written there, moving from deeper to lighter sleep. So any time you're going from deeper sleep to lighter sleep, that's an arousal. You don't have to physically wake up or toss and turn. It's just the brain going from a stage of deeper to lighter sleep. And often that transition from a deep to light sleep can cause some RMMA or Bruxism at the same time. So a question from Neela. Thank you for a great presentation. You're welcome. A question regarding level 3 and EEGs. Does SOMFIT level 3 use electrodes on the forehead to ensure the brain activity, to measure the brain activity? you have any experience with this level 3 study and your thoughts on using this as a screening study for patients? Um, yes, think I've used a SomFit. I can't remember all the names of these devices. Let me just Google it. I can't remember what it looks like. Uh, Yes, I have used a Summit. Yes, yes, it was that one I was thinking of. I forget all the names of these devices. Yes, I've used it myself on me and also on patients, and it's I think it's a level. I'm pretty sure the Somfit is actually a level 2 study, but it was diagnostic enough to use as a diagnostic study before treating a patient. All right, Angus Henderson. In the past, humans had two sleeps rather than one complete 7 hour sleep. Any thoughts about that? Uh, I feel as bit as a medical issue, not dental. How do we address that with patients? Uh, I don't understand the question properly. It sounds like to me you're saying we used to sleep 2 times a day rather than just once for 7 hours. So ideally, if we sleep, we should have about 8 to 9 hours of sleep, ideally, because, uh, well, recent research has actually shown that when we go to sleep, the brain flushes and cleans out the brain. It's the glymphatic system. So we have the lymphatic system, which is the immune system for our body, but we have the glymphatic system in the brain, has the glial cells, which flushes out the brain and cleans it out, which is how it can reduce risk of like what's it, Parkinson's, what's it, dementia, and all those sort of brain conditions. Now, for that glymphatic system to work to its full potential, you need 8 hours because that's how long it takes for that glymphatic system to drain and flush out the whole brain. So ideally, we should be having 8 to 9 hours of uninterrupted sleep so we can give the brain enough time to flush that all out. Now, it can be difficult to get that for some people, but if we're also doing like sleeping 2 times a day and you're trying to get 8 hours in those time, you're basically sleeping all the time. So they do say if you were to nap during the day because you were tired, ideally you should nap for no longer than 15, 20 minutes. Because if you nap for longer than that and start going to your deep sleep, and then you interrupt your deep sleep, like you set an alarm for an hour and you interrupt yourself in the middle of your deep sleep, you're actually going to feel worse than having a nap for 15 minutes where you're still in sort of N2 sleep. And if you start yourself and wake yourself up in that, you won't feel that sort of like hangover effect. I can't remember what it's called, but it's like that they call it like a fallback effect or something when you wake up and you feel all groggy. So often when we nap, we shouldn't nap for more than 15 minutes. A 15-minute power nap is ideal to get your energy up, not feel too tired and unrefreshed because we've probably all been guilty of having a 1 or 2 hour nap. We wake up and we sometimes feel even more tired after that because we didn't have to get a full proper cycle and we interrupted in the middle of a deep sleep cycle. So I hope that sort of answers that because I didn't fully understand the question, but I hope that made sense. All right, Alex McDonald, do you think the severity category has the potential to be misinterpreted by a patient? I prefer that part that was removed from the report as really clinical correlation is required. Yeah, yeah, I know what you mean. Yeah, so people, we're all humans. We want to see our reports. We want to read it and archive it, save on our desktops so we can always look at it, but we'll never look at it again. So yes, I think it would be good if patients were getting their copy that if they couldn't see the all the summary and results, because that can if they're seeing it before I get to talk to them, can skew things. Like it's the same as if they get the like an OPG report without seeing the OPG and they see all these carries and all these things on the OPG report, but they don't know what it means. But then we look at it and say, oh, never radio lucency, that's nothing. That's just your mental foramen. So, yes, but ultimately, probably always going to have these severities and correlations because these reports normally would go to a medical doctor of some sort, and if it gets into the patient's hands, it's going to fall into the patient's hands. So we're going to need those categories at some point on the study to just help summarize it and for the doctor or referring physician to be able to interpret it easily and quickly. All right, question from anonymous attendee. When does CPAP machine play a part in OSA treatment? Can play a part in any part of OSA. So CPAP is the gold standard treatment for sleep apnea because it's always going to work better than a mass. The downside of sleep with a CPAP is it's got very low compliance. And the low compliance is due to, well, it's difficult to use, it's uncomfortable. Well, it's not the sexiest thing to wear at night. If you're a 25-year-old female with severe apnea and you're told you have to wear CPAP for the rest of your life at 25 years old, yeah, good luck with that. Like they're going first thing going to their minds, oh, how am I gonna, get married? It's gonna be so embarrassing going on dates and bring a CPAP with me everywhere. So they're really useful, of course, but have very low compliance. And most of the research shows people after 4 or 5 years, only 40% of people are using it, or less than 40. And the ones who are using it, they're only using it for 3 or 4 hours at night, which isn't even the full night. So isn't even doing anything then. So it is useful though, because I have lots of patients who they just don't qualify for a mass. I look at a math and see, no, a mass won't work for you because you've got missing teeth or you can't protrude your jaw enough. Or we've tried a mass, but the mass just didn't work. And I say, I'm sorry, mass just doesn't work for you. We have to use a CPAP in your situation. So CPAP is a very useful thing. I do refer lots of my patients for it. I have patients in mild, moderate, or severe apnea with a CPAP. So normally with mild apnea, CPAP can be overkill, but it all depends on the patient. If they're a class 3 underbite patient, very narrow maxilla, and you can see they have limited protrusion, they wouldn't be a good candidate for a mass. So that's why I'd be saying, I'm sorry, I can't make you a mass. It just won't work for you. CPAP would be the way to go in your situation, or maybe, surgery or orthodontics to correct a underbite. So yeah, it depends. It really depends on what you're looking at and what the patient presents with. Uh, okay, people, Peter Newen. I have a patient that has reported pain in their teeth after starting to wear the 3D nylon mask. Is this normal? And have you encountered this feedback in your patients? How do you adjust a mask appliance if their dentition change and they need restorations? Tricky question to ask to answer, sorry, without seeing the patient and their bite. Pain in teeth, yes. I tell my patients with any appliance, whether it be 3D printed, acrylic, metal, haven't given anything metal in years, haven't given acrylic for a number of months. But yeah, even with 3D printed nylon, it still can cause discomfort on teeth. And it does depend on like the undercuts, the occlusion, and also depends which teeth you're talking about. So when the mandible is pushed forward with a mass, most of the forces we generate around the anterior area, normally around the lower anterior teeth. So if people do get pain on teeth, it's normally on the top or bottom anteriors. Now, the most common teeth, which people complain to me about, would be the canines, would be the upper canines or lower canines, because they're the anterior teeth, they've got a very long root, and if their mandible is being pushed forward, most of the force will generate around the canines. So most of the time, if I'm adjusting teeth, it's splint around teeth, it's normally around the anteriors or around the canines. It's also commonly around patients with very crooked, crowded teeth. So if they've got very crooked lower anteriors, often they'll come in to me and say, it's going great, but it's always sore around the 3-1. When I look at the 3-1 is the most crooked tooth, and it's normally the most anterior buccal tooth. So the more crowded the tooth, the dentition, and normally the most anterior tooth will be the one who will get most of the force when it's being pushed forward. And often that will be the tooth you'll need to adjust the mass around. If you're getting pain on all teeth, on all of your cases all the time, even though you're using 3D printed nylon, I'm then questioning, are you using scanners or impressions, or are you pouring molds? So maybe it might be the quality of scans or molds or impressions. It might be the lab you're using. Those are all the only things I could think of there. And so how do you adjust a mass if a dentition change or any restorations? Well, I'm assuming they've you've given them a mass, a 3D printed net mass, and they get a filling, and now the mass doesn't fit, and now you want to adjust it. I just use burrs, just like you would with acrylic. I always tell my patients to bring their mass to because I didn't do any fillings. So I have no drills to adjust a filling in my clinic. I have no dental chair. I only have a slow piece handpiece. So I can't adjust the filling or crown. So I told them, whenever you go to your dentist for anything, bring your mass, because if you get a filling or crown, I want your dentist to check it and adjust the filling or crown. If they can't adjust it to fit in the mass, come back and see me. I will adjust your mass. Now, if the patient is getting a crown, for example, I'll tell them, bring the mass, give the mass to your dentist to send to the lab with the crown, so the lab can make the crown as close a fit or perfect fit as possible into the mass. So they won't have a mass for 2 or 3 weeks, but at least we're guaranteed to have a much better fit without having to readjust it or, worst case scenario, make a new mass. So I have made, that's the downside of nylon. You can't reline it, so you can't get the lab to realign it. You have to either adjust yourself with burrs, and you will need to use a tungsten carbide burr. Acrylic burrs won't cut nylon. You know, tungsten carbide slow speed burr. And yeah, if you just can't adjust it around the tooth, then you'll need to remake it. And I normally charge the patients the lab fee. So I warn my patients, hey, if you get a filling, if it's just 1 or 2 teeth, bring the splint to see me. I can normally adjust if it's 1 or 2 teeth. But if you have like 5 or 6 teeth done, I probably can't adjust it. We'll need to remake it. It will cost you a lab fee, which will be a few $100s. If I tell them that at the start, they normally don't mind if they know it's going to happen. And if it's like 2 or 3 years later to get that filling and it doesn't fit, they're like, oh, well, it's been 2 or 3 years. It's only another few hundred to make it again. Sure, let's go make it. So do all that informed consent at the start. My local sleep clinic doesn't give any EEG measurements for master activity. Which sleep study company do you use who can assess Bruxism with level 2? I use, in Australia, I use AER, the AER Healthcare. They're in Sydney. They have the Bruxism EMG electrodes. One of my other, oh, I can't remember. There's another one in Melbourne that they were doing. I can't remember what they're called, but AER is one of the labs I use often for most of my sleep studies. I've been using AER with Chris Kelly for many years, and they're in Sydney. And AER sends their sleep study around Australia. All right, Jessica. So, is there any early intervention that can be done for infants less than 12 months who thumb suck to try and prevent jaw changes that may increase sleep disorders? Yes, definitely. Especially if they're a thumb sucker, start myofunctional therapy ASAP. So you would look for speech pathologists or oral health therapists, myofunctional therapists, dentists who have done any sort of myofunctional therapy training. So you have to stop them sucking the thumb. You might be using devices like, myomunchies. Those are great devices, especially for infants and babies. So it works just like a dummy. Instead of sucking with a thumb or a dummy, you put the myomunchie in their mouth. It's just a very soft mouth guard designed to push the jaw forward, open the airway, and get them to munch on it to grow and expand the upper and lower jaw. So look up Maya Munchie. They're made in Australia by Maya Munchie is just a company, and Dr. Mary Burke, she is a chiropractor. Her father was a chiropractor who invented Maya Munchie, and they do distribute Maya Munchie around the world. So that's a very useful device for children, especially for infants and babies. And they do have a baby size Maya Munchie. So my 1 year old niece, she was a mouth breather and thumb sucker. So I gave her a Maya Munchie at like 3 months old because she kept sucking her thumb. So I gave it to my brother, say, hey, quick, put the Maya Munchie in her mouth, get her to use that to help stop her thumb sucking. So very useful and does work. And kids love it. They love it. They just want to chew on something. And because it's soft and rubbery, they get into it straight away. It's not very hard for them to use. And they don't need to use it for like, 2 or 3 minutes a day. Uh, do patients have to wear masks for life? Yes. Very easy question. But it depends. If they get better, so say for example, they lifestyle changes play big role sleep apnea. If they lose weight, or if they, for example, have surgery because they have a blocked nose or tonsils or adenoids, then sleep apnea gets better and they have no more sleep apnea on their new sleep study, they may not need the mask forever. But majority of our patients, if they're not doing any other interventions, they will probably need to use the mask for life. Just to confirm, do you own multiple devices and learn them out to multiple patients, or do you order a device for each patient individually? Yeah, so I have a few of these good sleep devices, and we basically like rent them out. So I like it costs us like $50 for the report and all those reports. So I rent them out for like 120-ish to the patient. So it'll cover the fee and also give us a bit of money as well. And if we rent them out, then the patient will give it back. If I just say, oh, you can do this test for free, when people get things for free, they normally don't take care of things or they won't give it back to you properly. So we rent them out, and I have a few of them, so we can rent them out over a few different people. And if they're all rented out, then we just have a page. Oh, we'll just have need to wait when it comes back. Then I can give this to you to use use for you when it's all ready. However, at the beginning of the lecture, you mentioned that how tired a patient feels is not a good indication of severity or presence of disordered sleep. However, you are saying that asking a patient how tired they feel after therapy is viable feedback on how successful treatment. I didn't mean it just by how tired. Use it with your with the test. So if you're just asking them at the start with no sleep study, no diagnostic test at all, and just saying how tired are you, that's not enough information. But if you've done a sleep study, you've done your math, you've done treatment, this is where I'm asking, going back to the symptoms. I need to know. Oh, sorry. I think we just cut off for a sec. Where were we? Okay, where's that question? Yeah, so I'm saying what I meant with that was bring it back to the symptoms of the patient. So if you've done the whole the sleep study, you've done your mass, and you're just purely relying on the numbers of your sleep study in the AHI, if the patient's still feeling, oh, yeah, my AHI is healthy, but I'm still feeling tired, you haven't really treated them, have you? And the same could be, it could be the opposite as well. If they're saying, oh, I'm feeling so much more refreshed, but the AHI is still like 10 times an hour and they have mild sleep apnea, even though they're feeling better, you haven't fully treated them yet if the AHI is still 10 times an hour. So that's why you use a combination of things. So we wouldn't just base treatment on teeth and fillings and extractions and root canals by just looking at a PA or OPG. We'll look at the x-rays, we'll look at the mouth, we'll look at ask the patient having pain, do our TTP test and perioprobing, etc. So we use a combination of tests and the patient's symptoms to determine what treatment we will do. And it's the same thing with sleep apnea. So the reason I mentioned all that about numbers and how tired they are is some doctors will just purely focus on numbers and they won't care about the patient's symptoms. Some doctors will just focus pure on the symptoms and won't look at the numbers. So we have to look at everything all at the same time to properly treat our patients. Can a CPAP machine cause any damage in the long run? There have been studies which have shown CPAP can cause bite changes. So mass can cause bite changes by pushing the mandible forward and causing like an underbite. CPAP can also cause a bite change because it works like a reverse headgear. And since the CPAP is pumping pressure on the midface, it can worsen the midface and push it all backwards and cause even more obstruction. So CPAP can cause that sort of facial change damage. They have said as well that CPAP can sometimes, prolonged use of CPAP can lead to central sleep apnea because since the patient is relying on the CPAP, the brain goes, oh, I don't need to use my muscles to breathe anymore. I'll just depend on the CPAP. And then it can lead them to develop central sleep apnea. So those are main negative consequences I would think of, I come to mind for CPAP for me. Another sleep doctor mentioned CPAP is not designed for long-term use. For someone who has been on CPAP for 20 years, should I consider any other treatments? My dad has zero point 0.2 incidents of OSA per night after 20 years. He seems happy with it and is rested but does not have power function. Should a splint suffice or should mass be considered? Uh, Hard for me to say because I don't know. I do know how CPAP works and the bare basics, but I don't know. I'm not as informative about CPAP compared to a sleep doctor or sleep scientist. So that's actually the first time I've actually thought of it. They shouldn't be used for a long-term time as well. Even though we know they can cause central sleep apnea and bite changes, but sometimes that's all we've got to use. Um, Hard for me to answer that because it would depend. I would have to see your dad and see what he look, or you would have to see what he looks like. What's going on with his jaw? Does he, how bad was sleep apnea originally? You could do a sleep, you could make a mask and do a sleep dive with the mask and see if it's treating his sleep apnea just as well as CPAP. So, especially since it's your dad, I'm sure he won't mind you doing some treatment for him to test things out and get him off his CPAP. I do have lots of patients who have both CPAP and a mask. So when they go traveling, they take the mask. When they come back home, to use the CPAP because they find the CPAP works better than the mask, but they don't want to travel with the CPAP. So you can use a combination of whatever you've got in hand. But yeah, I really can't give much opinion about your dad without seeing him or having more information about his history. iTero. Oh, so you had iTero scanner. That was about the. Yeah, if you're getting pain in your teeth, it depends. I have to know what teeth. Is it every patient? Is it all the teeth? Is it always just the front teeth? Yeah, it might be the lab. I'm not sure. But yeah, if you're using a scanner, most likely it's not your scans. I'm guessing it's probably just the tightness of the splint, or maybe it's those front teeth, as I said, or pushing your jaw forward and just generating force there. Maybe it's your bite registration. Maybe your bite registration is too much vertical or too protruded as a starting point, and it's too much for the patient's teeth to handle. So it could be your bite registration. What instructions do you give patients with mass? How often do you review patient with mass and how far do you protrude? That's a whole lecture. um, to do that quickly, I tell my patients, wait at night, in the morning, you might feel some discomfort in your teeth, especially for the first few days. You might feel bite changes. I'll give you a morning aligner to stop the bite changes. I'll teach you exercise to help you stop the bite changes. If you get TMD, don't use it until I check your splint. Don't protrude I tell them to protrude it. I'll give them 2 weeks before they start protruding, just get used to it. And each titration, I tell them to give 2 weeks on each titration. There's no set criteria on how much titrate and how long to wait between titration. But that's what I use. That's what I do. I do 2 weeks if needed, depending on how the patient is feeling. And I try to protrude as little as possible. So I never protrude all the way to maximum. I always do as little as possible, depending on patient symptoms, their bites, and those sort of things. Thank you for a great seminar. How do you record the bite for mass? I used a phonetic bite registration. So I'm not a big fan of George Gage or bite forks because, well, when I first graduated, my DA went to a course and I went a sleep course, and they used it as a demonstration, and they did a George Gage, and they dislocated her TMJ and locked her jaw, caused massive TMD. She couldn't open her mouth, and I was 3 years graduated, don't know what's going on. We had to try and lock her, so that put me off George Gage's forever. So I'm biased against George Gage's, but then I did more training in TMD and started learning the phonetic bite, which is much more gentler on the TMJ, especially in the TMD case, because it doesn't protrude the jaw as much. And we're also using less vertical compared with like a bite fork. So bite forks are useful though, as long as you're careful. So I know lots of very qualified sleep dentists use bite forks and George gauges all the time, but they are careful with their TMJ patients, or even though they have no TMD, they're very careful how they're using it, and they're monitoring and make sure they're keeping the midlines in the correct position, not over opening, they're not creating any cants or distortions. So you could use George gauges, you could use bite forks, but I prefer using the phonetic bite. But as long as you're doing proper screening and assessment of the TMJ before, during, and after treatment, you should be fine. Okay, last two questions, then we'll have to call it a night. I may have missed your explanation on this. What criteria do you use to decide the level of sleep study you employ on a patient? I'm always using level two for my diagnostics because Mako legally in Australia, I need level two, but I was to determine it on, how much well, my level twos aren't too expensive, about 200 Aussie, so not too bad. And I, on their location, where they come from, how easy it is for them to access, whether like people with ADHD or sensory disorders, they may not like having all this stuff on their body, and we might have to use level three or level four in those sort of situations. So depends on the patient, but majority of my patients are a level two or three. Do you have any recommendations for my functional therapists in Melbourne that work with babies? Yes. My functional therapist, there's the My Functional Center, Donny Mandrawa. I've sent him a lot of my patients. They do have a bit of a wait list at the moment, though. So if not the My Functional Center, there's Nicole Hutchinson. She's a she's a speech therapist. There's Carmen Chan. She's a pediatrician dentist, a pediatric dentist in Essendon and Werribee. So Carmen, that's Kar, then space Mun. She's a pediatric dentist who does tongue ties and myofunctional therapy. There's also Hannah Rose. She's in where's Hannah? She's in Heidelberg area. And there's also Bronwyn Cameron. She's in I think it was around like South Melbourne area. So yeah, hope that helps out. All right, I think that's all we've got for tonight. Thank you all for attending. And if you want to reach out to me, feel free to email me or message me and look out for the emails from Joel and good sleep over the next few days.
Thanks
Have a
very
good
much.
night, guys.
Yeah, thank you, everybody.